I will be presenting a case on myocardial infarction. And this patient, initial LG,
Please speak up, speak
is
up.
a
You're a man, speak
69
up.
years old, a retired school teacher, came to the hospital complaining of chest pain after climbing a flight of stairs at his daughter's house. So, history of illness. This patient has been diagnosed of hypertension 10 years ago, and recently has been diagnosed of type 2 diabetes and is on diet control. He smokes more than 40 sticks of cigarettes per day and drinks approximately 10 units of alcohol per week, and also have osteoarthritis. Okay, family history. The father also died of this same disease, myocardial infarction, a 60 years old man at age 60. And this person is allergic to trimethoprim antibiotics and past medication. The patient has been on diclofenac because he's hypertensive, 75 milligrams twice daily, and also um, sorry, because of the osteoarthritis, he has been on diclofenac, and then nifedipine for the hypertension, 20 milligrams twice daily. Also, while in the ambulance, on the way coming to the hospital, he was administered 300 milligram uh, aspirin. So, on getting to the hospital, the following medications were given: heparin, 5,000 units starts, Retiplex 10 units IV bolus, followed by a further 10 units IV bolus 30 minutes later. And also diamorphine, which is heroin, 2.5 milligram IV stats, metoclopramide 10 milligram stats. And the following tests were run: the full blood count, liver function, electrolyte, renal function, cholesterol level, and blood glucose. So the ECG scan shows that there is a ST elevation of about 3 millimeter in inferior disc, which means there is a ST elevation in this pre-myocardial fluid. There is a blockage, total blockage of the vessel, the coronary vessel. So from this medication, I was able to identify about two drug therapy problems, which is this patient was administered heparin alongside recently, which is a thrombolytic agent, and heparin, an anticoagulant. So this increases bleeding. It increases the risk of bleeding. So the intervention for this is to monitor the activated partial thromboplastin time while this person is on heparin to adjust the dose to avoid bleeding. The activated partial thromboplastin time is actually a test to monitor the time it takes for the blood to clot. And from standard recommendation is about 20 to 35 seconds. So, but if this person is on heparin, you actually multiply this standard value by 1.5 to 2.5, which is the control value. So when the range is below or above this range, you can taper the dose of the infusion to be or to fall on the range to avoid bleeding. Okay, and the goals of therapy here is to relieve pain, reduce cardiac workload, prevent further thrombosis, improve long-term outcomes, and prevent and treat complications. So our question for this cluster was: following the initial dose of heparin, 5,000 units, what dose of heparin should be administered by IV infusion and for how long? So my colleague here will take the first part of that question.
Good morning, class. Good morning, sirs. Okay, like what my colleague has told us, following the initial dose of heparin, 5,500 units starts, what dose of heparin should be administered by IV infusion and for how long? Okay, according to Nigerian Standard Treatment Guidelines 2006, as recommended, acute coronary syndrome (ACS) for anticoagulants, initial loading dose should be 60 units per kg, which is 4,000 units, followed by an infusion 12 units per kg per hour, which is the maximum of 1,000 units per hour. Then we now adjust to therapeutic APTT. Now, the standard protocol also says that American College of Cardiology and our American Heart Association for or European Society of Cardiology say that the initial infusion rate should be start with 12 to 15 units per kg per hour, which is the maximum of 1,000 units as a continuous infusion, IV infusion. Then you now adjust and